auto-PEEP?
Yep. So this patient, AC, so then frequency, tidal volume, and then PEEP, and then FiO2. So kind of just looking at the vent. So you start off this patient's at a frequency of 24. So this is settings at the bottom, right? Frequency of 24. Tidal volume is 500 milliliters. Time those both together, you get the minute ventilation of the patient. So you see how many liters that they're breathing in a minute. And then you do PEEP, which is here. And then you do oxygen, which is down here. So those are the kind of how you present it. When you look up here, so this is the settings, this is what you set with the ventilator. Up here is what the patient's actually doing, right? So, a patient can always overbreathe the vent. They can have a higher frequency. They can have a higher tidal volume. So this is what really the patient's doing in real time. All right, so just looking at these curves. So this patient is also on volume control. So we control the amount of volume. So the other variables that are going to be in this is going to be flow, and it's going to be pressure. So this is a pressure curve here. So just drawing it out, and you guys might want to pay attention because pretty much all the questions I'm going to ask you can probably answer with the stuff I'm about to do here. So here is your basic unit of the lung. Here is your bronchi, and all the way up to your trachea. I'm just not going to draw it. So bronchi, and then here's your alveoli. All right. So when you look at your pressure curve, so right here is going to be the patient's inspiration, right? So if you look at the curve, this is where the patient starts inspiring right here. So they breathe in, and then their flow is kind of higher at first, then decreases, and then they stop breathing in. Oh, what happened here? They stop breathing in right here, and then their flow goes negative here because they start breathing out. They start breathing out, and then they stop breathing out here, and they kind of go, they restart that again. And then you can see that on the pressure curve as well. Here's your inspiration, and then right here is your expiration. So remember, breathing in, inspiration, and then breathing out. So my question for you guys is, here is your peak inspiratory pressure. So what two things kind of go into making your peak inspiratory pressures? Where is that pressure coming from?
Airway flow and then the resistance.
What's that?
Airway flow.
I can't hear you guys that well. Well, I'll just give it to you then. So where that pressure is coming from is going to be pressure with inside the bronchi and trachea itself. So it's going to be airway resistance. And airway resistance is really a addition of two things, right? So it is, or kind of a combination of two things. It's how fast your flow is, so how fast that air is going in, times this is airway pressure, my bad, times airway resistance. And what type of things can increase your airway resistance? Does anyone know? There's one major one.
Bronchoconstriction?
Yeah, anything that increases bronchoconstriction. So what bronchoconstriction is going to do, it makes those airways smaller, more surface area is actually air is going to be going past more surface area. because it's actually going through a smaller airway, and that those airway, that basically that laminar flow is going to slow down that air movement, increasing the pressure. All right, and then, so you have your airway pressure here, then you also have your alveolar pressure. So does anyone know what is the thing on the vent that tells you what your alveolar pressure is? What is the, and you can see it actually here. So this is the kind of the pressure that's intrinsic in your lungs. It's the pressure that it takes to open up the alveoli. So anything that inhibits opening up the alveoli will increase this number, or this kind of
Your peaks?
not your peak, so actually your plateau pressure. So this is really your plateau pressure, P flat. So overall, your PIP, now flow is done by the ventilator, so it's kind of depends on the ventilator. So really your PIP is your airway resistance plus your plateau pressure. And the way that you actually get a plateau pressure is you have, so you see here, the patient breathes all the way in. So you see the patient breathing in here, the flow is positive. And then everyone can do this, breathe in and then stop. So they breathe all the way in and then you stop. And then when you breathe all the way in and you stop, it actually takes out any of the intrinsic resistance of the airways. And what you're left is just your alveolar pressure, or the pressure that it takes to open up that alveoli. And that setting is called your P flat. So that is your P flat. So your peak inspiratory pressure equals your airway resistance, which is mostly, sorry, I keep doing this wrong. Your airway pressure, which is mostly measured by your airway resistance. So it'll increase by things like bronchospasm, plus your plateau pressure, which is really the pressure that it takes to open up those alveoli. So that's what gives you those peak inspiratory pressure, is your airway pressure plus your plateau pressure. Does anyone know how to get a P flat on a ventilator? Does anyone know how to do it? It's like the only button you can touch on a ventilator to get a plateau pressure.
Inspiratory hold?
Yeah, so you actually go up, and this is like really the only thing you should ever touch on a ventilator is touch that inspiratory hold. And that inspiratory hold will give you your plateau pressure. And then from there, you can also get your airway pressure as well. All right, so pretty much with that, with doing a plateau pressure, you can get, and having the peak inspiratory pressure, which is right here. So here's peak inspiratory pressure. You do a hole and you get the plateau pressure. You can also get a surrogate for airway resistance. So this, airway pressure or airway resistance, it's kind of, airway resistance, airway pressure that, once you account for the variable of flow, airway pressure equals airway resistance. So you can actually just redo this formula and say airway resistance equals PIP, so your peak inspiratory pressure, minus your peak plateau pressure. Because remember, when you do that at that plateau pressure, you're taking a breath in, you're holding it, so all the pressure in your lungs is coming from your alveoli, and anything that's going to inhibit opening up those alveoli are going to increase your plateau pressure. All right. The last thing that we're going to talk about before we get to questions is your I to E ratio. So if you see these patient breathing here, so remember, flow is positive right here. Here's your inspiratory. Flow then becomes negative right here. So this is your expiratory. So same thing on the pressure curve, inspiratory, and then expiratory here. So I to E ratio is something that you can really change on the ventilator. And one way that you can actually change it is by changing your flow. So flow is basically the velocity in which you can take a breath in. So if you increase the velocity, so the inspiratory flow, so you increase the velocity that you take a breath in, that's actually going to decrease your time that you're in inspiration. And it's actually going to decrease your I to E ratio. That's something else we're going to kind of talk about later. So just remember, if you increase your inspiratory flow, that's the quickness of how quick you deliver a breath. You decrease the amount of time that you're inspiration, and you're going to actually decrease your ID ratio. So we got most of the confusing stuff out of the way. So we're going to go to Kahoot now. So this is our first question. So this patient, 68-year-old male, past medical history of T-cell lymphoma, status post allogeneic stem cell transplant 1 year ago. That was complicated previously by acute graft-versus-host disease. He's admitted to the ICU 6 days ago for ventilator support after experiencing acute worsening of his dyspnea, respiratory failure, and CT scans show that he had pneumonitis. His predicted total body weight is 60 kilograms. Pulse ox is 89%. Gas shows a pH of 7.31, a CO2 of 70, an O2 of 79, and a bicarb of 33. On AC ventilation, respiratory rate of 18, tidal volume of 420. I did this backwards, but PEEP of 14 and an FiO2 of 50%, a plateau pressure of 20, and a PIP of 25. So the question is here, what is this reason for this patient's hypercapnia? Is it because the patient has increased airway resistance? Is it because the patient has a high FiO2? Because the patient has a high PEEP? Or is it because the patient has high dead space? So we'll go back to Kahoot. For answering of this, and we'll start. All right, got about 30 seconds left. Oh, wow. Okay. All right, so let's go over this one. So I think a lot of people thought it was due to increased airway resistance. The first thing I just want to go over is what is the formula for ventilation, right? So anytime you think of ventilation, so ventilation equals respiratory rate times tidal volume minus dead space. So here's your respiratory rate, this is the bronchotrachea going in, going out. And then really all of this area is your tidal volume. All of this area will be filled with air, oxygenated air, during respiration, right? So the question is, what is dead space? So dead space really is area that doesn't involve gas exchange. So you have physiological dead space, right? So your trachea is not involved in gas exchange, it's not the alveoli. This is physiological dead space. But in patients who have really severe lung disease, and this is usually acute, so patients that have pneumonia, really bad ARDS, really bad PE, anything that actually at a parenchymal level destroys those capillaries, so causes really bad destruction of those capillaries, basically that CO2 is not allowed to diffuse out into your alveoli. And because of that, these patients aren't able to expire a lot of CO2. So kind of going over the answers of this one. For the first one is, I think a lot of people thought it was due to increased airway resistance, but let's go over this again. So remember that your peak inspiratory pressure, so PIP equals airway resistance which is a kind of a surrogate for airway pressure once you just say flow is constant. So airway resistance plus P plat. So we have all these numbers here, right? So this plat is 20, the peak is 25, which means that the airway resistance here is 5. So that's actually a normal airway resistance. That means that this patient does not have any evidence of bronchospasm. This patient doesn't have any narrowing from a mucus plug. It doesn't have a kink in the ET tube somewhere. So the airway resistance for this patient is actually normal. So, using that kind of formula, we can tell that, this patient is not hypercapnic because of increased airway resistance. Next one, increased FiO2. There is the theoretical concern with someone that gets high FiO2 that causes, vasodilation to the lungs in areas where, there should be hypoxic vasoconstriction, and that can worsen dead space ventilation. So there is that theory, but this patient's not hyperoxic. If you look, he's on FiO2 50%, but his O2 is actually 79 from his ABG, which is not hyperoxic, and his pulse ox is 89%. So he's not having really shunting from that. The next one that was incorrect is high PEEP. PEEP doesn't really do much. If you kind of look at the ventilation equation, PEEP really isn't in here. It's more of a function of your respiratory rate, your tidal volume, and your dead space. So the actual correct answer here is this patient actually has a lot of increased alveolar dead space. This patient is breathing enough for if he had normal lungs, he would be completely fine and he would not be hypercapnic, right? His respiratory rate here is 18 and his tidal volume is 420. So his minute ventilation is about, those two times each other. So it's about 9 liters. And a normal minute ventilation is around 5 to 8 liters. So what's going on in this guy's lung is that he's having acute graft-versus-host disease with really severe pneumonitis, and he's actually causing destruction of a lot of those alveolar capillaries, causing a bunch of dead space in his lung that's actually not involved in CO2 exchange. And since it's not involved in CO2 exchange, the CO2 in his blood is going up. So that was the correct answer for that one. And that's kind of mostly all the stuff about ventilation. Just remember, ventilation is respiratory rate times tidal volume minus dead space. And whenever you see someone that's hypercapnic, and they don't have high airway resistance, looking at their PIP and their P plat, and their minute ventilation is like 5 to 8 or above, the reason why they're hypercapnic is because they have destruction of their lung, destruction of those capillaries, poor transfer of CO2, and subsequently increased dead space. So that was the question here. And I think you get this on rounds a lot where someone has a minute, it's a patient with severe ARDS and they have a minute ventilation that's, 12 liters. And they'll ask you, oh, why does this patient's minute ventilation 12 liters with a severe ARDS? And it's because they have a lot of pathologic dead space in their lungs. All right. So question 2, this one's kind of going over oxygenation. So which one of these changes on the ventilator will not increase this patient's oxygenation? Will it not be increased by an increased FO2? Will it not be increased by increased PEEP? Will it not be increased by an increased respiratory rate with the same inspiratory time per breath? So same inspiratory, like time, amount of time per breath in inspiration. Or will it not increase with an increased inspiratory flow rate? So which one of these will not increase the patient's oxygenation? And these questions are, they're tough, but I'm really just trying to teach ventilator physiology. All right, let's see who is that one person. Cash, good job. All right, so question 2. about 30 seconds. I think I may be a little too long. About 10 seconds left. All right. So let's go over this one. Oop. My computer's on the fritz. Sorry, guys. So let's kind of go through oxygenation, and let's go through the formula for oxygenation. So the formula of oxygenation equals area of the alveoli over thickness of the alveolar capillary interstitium times the partial pressure of oxygen in the alveoli minus the partial pressure of oxygen in the blood. So area of the alveoli, this is, we can't change this, right? Things that are going to really decrease this surface area of the alveoli are going to be things that call it alveolar filling, like pneumonia, non-cardiogenic pulmonary edema, atelectasis, right? This is going to be pathology that's going to change this. Thickness of the alveoli, we're not really, this is stuff that calls pathology as well, right? This is going to be things like interstitial lung disease that causes, fibrosis that, decreases diffusion of oxygen from your alveoli to your capillary. The only thing that we can change is the partial pressure of oxygen in your alveoli. And everything that we do on the ventilator is to change this. So kind of let's look at the ventilator. I think the thing that really helps me is we went through flow. So this is flow. This is when you're in inspiration. This is when you're in expiration. And this is your pressure. So actually the pressure curve, the area under this curve is your PaO2 over time. So anything that's going to increase this, basically the space under this pressure curve over time is going to increase your PaO2. So let's look at some of the things that can cause that. Now the first one is pretty simple. I'm not going to go into too much. Is going to be increased FiO2. If you increase the FiO2, your PaO2 is going to go up. Pretty obvious. The next one, and maybe not, it may not be as obvious, is increasing your PEEP. So you see over to the left here, this is your pressure curve again. I just made it a little bit different this time. And here's your PaO2, right? All this area under this pressure curve is your PaO2 over time. This patient's PEEP right now is around 5. So look what happens to the area under the curve, under the pressure curve, when you increase the PEEP to 10. That patient's partial pressure of oxygen is going to be increased throughout the entire respiratory cycle during inspiration and during expiration, making that patient have an increased PaO2 over time. So that is the way that PEEP will increase your oxygenation. So that will increase it. So this one's hard, and you probably would never do this. I just made this a question really to teach you about inspiratory time and expiratory time. So if you guys remember, here's your pressure, here's your inspiratory time, here is your expiratory time. So pressure is, and then here's basically where the patient's transferring from breathing in, holding, and then breathing out here. All right. So what is going to happen when you maintain this inspiratory time, but then you also increase the patient's respiratory rate? Now the IDE ratio here is probably about 1 to 2. Now look at the IDE ratio here. It's actually about 1 to 1. And what you just did is they're spending a lot more time in inspiration. And when a patient is inspiring, there is more air in their lungs. So their PaO2 in their lungs is actually going to be increased. So you can see it increases that area under the curve of the pressure curve. So it's going to actually increase their PaO2 over time. So that will increase their oxygen. last one is, and this is where I think I tricked you guys, and there's a lot of double negatives, and I think this is why it's hard when you get some of these questions on rounds, is what's going to happen with when you change their inspiratory flow rate. So once again, here is your IDE ratio. So here is your inspiratory time. Here is your expiratory time. So one thing that's going to increase your oxygenation is actually decreasing the inspiratory flow rate. And when you decrease that inspiratory flow rate, the patient takes a longer time to get that same volume. So you actually increase the time in inspiration, and which actually will increase your IDE ratio. So you can kind of see it right here. So here is, the inspiratory time is right here. This person, we slow down their inspiratory flow rate. It takes longer for them to get that volume. And here the IDE ratio is around 1 to 2. Here that IDE ratio goes 1 to 1. And if you look at that area under the curve now, remember the area under the curve is PaO2 over time. You just increased it. You just increased that area underneath that curve. So you're actually going to increase your PaO2 over time, which is why in this one, so if you increase the patient's inspiratory, flow rates, let's write that out a little bit. So what's going to happen is that they're actually going to spend a shorter amount of time in inspiration. And with that shorter amount of time in inspiration, that area underneath the curve is actually going to decrease their PaO2. So this one, the inspiratory flow rate will not increase the patient's oxygenation. Very hard concept, but questioned a lot, and I think questioned a lot on rounds, and I think kind of requires you to learn this and to really know the IDE ratio. So just remember, inspiratory. If you increase the inspiratory flow rate, you decrease the amount of time that this patient spends in inspiration, which will then decrease your patient's PaO2. All right.
You put a question in the chat.
Oh, okay. Sorry, I wasn't looking at the chat. Danielle, we're actually going to get I think our next question, we're going to get into normal airway resistance, and we're going to get into normal plateau pressures as well. So I'm going to answer that. All right. Oh, and this is the question. I'll just give you this actually. So normal airway resistance, which is when you make flow a constant, airway resistance, so I'll just say AR equals your PIP, so your peak inspiratory pressure minus your plateau pressure. And it should be less than 10. So this is our third question. 23-year-old lady has a history of severe uncontrolled asthma, 2 previous hospitalizations for asthma in the last year. She's presenting with worsening dyspnea. She's intubated in the ED for hypercapnic respiratory failure. She's sent up to the ICU. She has diffuse wheezing on exam. Her admission ventilatory waveform is shown to the right here. And her admission vent readings are a PIP of 42, a plateau of 20, and a PEEP of 10. All right. What is the cause of this patient's high inspiratory pressure? Is it increased airway resistance? They have a right main stem intubation? They have decreased lung compliance? Or does the patient have ventilatory dysynchrony? So we'll get back to Kahoot. All right, Cash still doing well. All right, got about 30 seconds left. Nice. Okay. Great job, everybody. All right. So for this one, the correct answer was increased airway resistance. All right. So this is kind of going into just going into it more your PIP, and then what can increase your airway resistance and what can also increase your plateau pressure. So what do you guys think? You can throw in the chat if you want to, some things that increase your airway resistance. I'll give you the first one. So first one is going to be, bronchospasm. So as you remember, as your airways narrow, more surface area, it actually has more surface area that the airway has to, that the air has to go through. That actually increases laminar flow, increases your resistance, which then will increase your airway pressure. So bronchospasm is the first one. So here, anything that causes, or maybe down here, anything that causes bronchospasm is going to increase your airway resistance. What else may increase your airway resistance?
Tube kinking.
Yeah, tube kinking. Yeah, so remember this airway goes all the way up to the ET tube as well. So if someone has a kinked ET tube, here it is kinked. It's not very good, but I try my best. Someone has a kinked ET tube, that's also going to narrow your airway, and that narrowing is going to go and increase your airway resistance. Perfect. That's one thing to absolutely think about. And all these things you're going to call respiratory for. Obviously, respiratory and a fellow. Is, vents are complicated. There's one more that can do it. And this may narrow it. Maybe someone who has a really hard time clearing. Yeah, yep, mucus plug. So yeah, and the last one is going to be a mucus plug. And once again, this mucus plug, may not plug the entire thing. And if it doesn't plug the entire thing, it's going to narrow your airways again. And that narrowing is going to increase your airway resistance. It's going to be hard to get breath down there, right? So mucus plug. All right, so there's a bit more for things that can increase your plateau pressure, right? So plateau pressure greater than 30 is abnormal, and a PIP greater than 40 is abnormal. So what type of things do you think can increase your plateau pressure? And when I think of plateau pressure, I think of anything that's going to inhibit alveolar opening is going to increase that alveolar pressure, and it's going to increase your plateau pressure. So can you guys think of some stuff that can do this?
Edema.
Yeah, so really anything that, really changes that alveoli, right? So anything that even causes alveolar filling, like ARDS, pulmonary edema, pneumonia can do this, and then anything that causes, increased elasticity or lowers the compliance, like alveolar thickening can do this as well, like someone that has interstitial lung disease, they may have a high plateau pressure. So perfect, yeah, first one is really alveolar causes. And I think the biggest one you're going to see most commonly is going to be ARDS and someone that's in the ICU. What other things can maybe do this? Let's see.
Obesity.
Yeah, exactly. So that's 4. So obesity can do this. So I mean, if someone's obese, they're having compression of their lungs, and they have that compression of their lungs. That's actually going to that's really going to make it more difficult for them to open their lungs, which is going to increase that alveolar pressure, going to increase that plateau pressure. So Yeah, obesity. So that's a big one, and something that you'll see in the ICU. You know, you'll see this in real time with someone that's obese having higher plateau pressures. Um, the third one, and I kind of make the obesity one just extra thoracic causes. So it can be obesity, but typhoid scoliosis, things like that. I've never really seen it before, but technically they can do it as well. So the other one can be like pleural causes. So you think of like a pleural effusion. So here's a big pleural effusion, or you think like even, or if you even think like a pneumothorax, these are all going to cause atelectasis compression and atelectasis of the lungs. And that atelectasis of the lungs is actually going to make it harder for those alveoli to open. So pleural causes, whether that's a pneumothorax or pleural effusion, they can also do this as well. And the last one is actually over-distension. So if someone has air trapping, their lungs are going to be over-distended, and really you're going to get those alveoli are not going to be able to as easily open up, and they'll start getting really, really stretched and actually damaged. You'll probably get some ventilatory induced lung injuries and villi from that. But over-distension can actually increase your plateau pressure, just because you're really maxing out the compliance of the alveoli. So those are the kind of the four things you got to think about with a high plateau pressure. But going back to this patient, this is really secondary to increased airway resistance. As her plateau pressure is 20, meaning her airway resistance is around 10 or 22. And this patient has high airway resistance secondary to asthma. All right, I actually wrote on the next slide, so I'm going to go straight to Kahoot on this one. All right, so I think this is the same patient. So I'm going to give you this. So what happens is that this patient has really high resistances, and then 2 hours later, the patient becomes really hypoxic, tachycardic. Her peak increases to 60 and her plateau increases to 40. She has equal breath sounds bilaterally. So really what happens to this patient is her plateau pressure really, really spikes. And the question is, why is her plateau pressure really, really spiking right now? And what do you want to do about it? So do you want to do the needle for pneumo, extubate the BiPAP, give Lasix, or disconnect from the ventilator, bag also tape suction? And sorry, you only have 20 seconds. All right, 10 seconds left. Okay, actually, a lot of you guys got this, even though I made it really, really difficult and stressful because I've actually read on the next slide, so I couldn't show you it outside of Kahoot. My computer is not doing cooperate. 1 second, my computer just stopped responding. All right. So whoever said D got this right. So yeah, like we were saying, this plateau increased to 40, her PIP increases to 60. Does anyone want to tell me what they think was going on in this case? Anyone who got it right? Anyone? I guess it's kind of a tough one. All right. So what went on in this case really is this patient started auto-PEEPing. So this is a case of auto-PEEP. Or also known as breath stacking. I think it's actually easier to think about it as breath stacking. So looking at this next slide, So, we're going to go back to inspiratory curves. I think this is helpful. So this is inspiration, right? So you inspire, and then you expire. So remember, inspiration here, expiration here. So your inspiration should equal your expiration. And if you don't inspire the same amount, if you don't expire the same amount that you inspire, you're going to have breath stacking. So everyone do this real quick. Take a breath, and then take a much smaller breath out, and then take another deep breath, and take a smaller breath out, and then take another deep breath, and take a smaller breath out. And then if you keep doing that, you can feel the pressure in your airways are going to start getting higher and start getting higher. So what was going on with this patient is she had asthma, and we were not allowing her to expire. So she's inspiring normally, but because she has so much bronchoconstriction going on, she's going to have dynamic airway collapse, and it's going to take her longer to expire. So COPD or asthmatics, they need to have a higher expiratory time. So you can see her expiring right here. And then what happens is that she doesn't fully expire because she has that bronchoconstriction, and she has resistance against airway flow. And before she's able to fully respire, you see that this does not get back to FRC. So this does not get back to zero. And looking at the flow diagram and seeing that the expiratory curve does not get back to zero is a huge, huge clue that the patient is auto-PEEP. And this is what the respiratory therapist will go towards the ventilator. This is what they'll look at to see if the patient is at risk to start auto-PEEP. So she doesn't fully expire out, and then she expires, and then she inspires again. So what does this look like over time? So it pretty much looks like this. So as you see, this patient doesn't get a full expiration, inspires again, and then doesn't get a full expiration. So your pressure in your lungs will start stacking. So here's our pressure stacking, and even the volume in the lungs will start stacking as well. So you have increased pressure and increased volume, and what that does is actually increase your plateau pressure. And you can feel it. If you start breath stacking yourself, you can feel that pressure building up in your lungs. So what do you do in these situations? So for these patients, you think they're breath stacking, you disconnect them from the ventilator, you bag them, you auscultate, obviously and we want to make sure, the plateau went up, so you want to make sure they didn't have a pneumothorax. And then you also, just suction them as well. So that's kind of what you want to do when the patient's breath stacking. And even at some question I've seen, like you press on their chest and you have them expire fully before you put them back on the ventilator. But the biggest thing you really want to do is disconnect them from the vent and stabilize them. So most people got this question right, which is good. This one gets a little bit more nuanced. So, when she came to you, there was hints in her flow, right? She wasn't going back to her FRC. She wasn't going back to zero. She wasn't expiring fully. So there was hints already that she was breath stacking, but it took a little bit for her plateau pressure to go up and her to decompensate to figure it out. So the question is how do you actually, what do you change on a vent that would have fixed this? So if you caught this, how would you have fixed this? How would you have allowed her to expire fully so that the patient doesn't breath stack anymore? And I think this is our last question. All right. Nice. Most people got this right. So going back, question 5. let's kind of go through these, right? So what's going to happen when you increase this patient's respiratory rate? So here's their IDE ratio. You increase their respiratory rate, and what's going to happen to their flow, right? So their IDE ratio is actually going to go up. And they're actually going to have decreased time in expiration. So look how much you just decrease this patient's time in expiration, right? So this patient actually, if you increase their respiratory rate, their expiratory flow is actually going to go further away from getting back to zero, and they're actually going to start breath stacking more. So they're just going to keep stacking breaths on top of each other, and they're actually going to give them less time to expire, which will increase their auto-PEEP. So that's not what you want to do. And I don't think anyone said that. So that was good. Next one is decrease the patient's PEEP. I mean, this really won't do anything. So if you look at this patient's volume curve here, the only thing this would do is it would decrease the PaO2, which would decrease their oxygen. But the PEEP wouldn't really, decreasing the PEEP wouldn't really do anything to allow this patient to expire. So increase the PEEP, there's really no change on expiratory time. All right, and then last one is decreasing the patient's inspiratory flow rate. So if you decrease the inspiratory flow rate, then these patients, so here's their inspiratory time, expiratory time normally, here's when you decrease the inspiratory flow rate. So when you do that, it's going to take a longer time to deliver a full volume controlled breath, which will make them spend a longer time in inspiration and a shorter time in expiration, which is actually going to increase their IDE ratio, which is not what you want to do here. Because this, as you can see here, will actually decrease the amount of time in expiration and will worsen breath stacking, which is why the correct answer was decreasing the patient's respiratory rate. So let's see what happens when you decrease the respiratory rate. So here's the IDE time of the patient. You decrease the respiratory rate here while maintaining the same inspiratory time, and look what happens. Here's your I ratio, here's your E ratio, and look what just happened to the graph. That expiratory is going back to the FRC, your functional residual capacity, where your lung, FRC, remember, is basically where your alveolar collapse and your chest expansion is zero. So you want to get back to that. You want to get back to basically where those two counteropposing forces is zero. Because when you get back to there on expiration, that's going to prevent breath stacking. So you can see that here. So that was the correct answer, was decrease the patient's respiratory rate. All right. So take home points. Just kind of go through these. Just remember, ventilation is dependent on respiratory rate, tidal volume, and dead space. And just remember, when you have a really high minute volume and low resistance, low airway resistance, and you're still hypercapnic, then you probably have a high dead space. And this can be caused by anything that's going to cause destruction of those capillaries, which is going to decrease excretion of CO2 into the alveoli and out, and subsequently out of the body. This could be anything. This could be any severe lung disease. It could be really severe COPD, severe ARDS, severe pneumonia. Any of these can really cause, even a severe PE can cause this. Remember oxygen diffusion. The thing that really is going to increase your oxygen diffusion that we can control is PaO2. The rest is really controlled by physiology and pathology. And ways that you can increase your PaO2 is first, increasing your FiO2. Second, increasing your PEEP. So look at this. Remember area underneath the pressure curve is your PaO2 over time. So increasing PEEP increases right here, increases the PaO2 during inspiration and during expiration, which is going to increase your PaO2, increase your oxygenation. The next one is increasing your rest. So this is not really something we really do. This is more for teaching. This is what patients do when they're hypoxic, and why they increase their respiratory rate is actually to increase their oxygenation. And when they do that and they increase the respiratory rate, they usually keep the same inspiratory time. So this is more of something people do when they're sick and hypoxic before they're on the ventilator. But if you remember, if you increase your respiratory rate while maintaining the same inspiratory time, you're going to increase the area under the curve here, increasing that PaO2 over time. And lastly, and this is the hard one, if you decrease your inspiratory flow time, you're going to increase the amount of time that you're spending in inspiration because it's going to take longer to deliver that inspiratory breath. It's going to increase your PaO2 over time. Those are all the ways that you can increase your PaO2, specifically bringing in the IDE ratio. So the 3 and 4 will increase your IDE ratio. So remember, increasing your IDE ratio will increase your oxygenation. Lastly, remember what increases your airway resistance, bronchospasm, mucus plug, ventilatory problem like a kink tube. And then remember the things that decrease your lung compliance or anything that inhibits that alveolar opening, which could be alveolar issues, can be lung overdistension, can be pleural effusions, and can be extrathoracic causes like obesity. And lastly, how to prevent auto-PEEP. So how to prevent breath stacking, right? And remember, this is a big hint for breath stacking is this expiratory flow diagram, not going back to zero before the patient takes another inspiratory breath. And things that you can do to really inhibit breath stacking, these are going to be in patients in COPD, asthma, patients that have bronchoconstriction, they need a longer time in expiration to get all the air out, is decreasing your respiratory rate. So look, if you decrease your respiratory rate, you're going to prolong that expiratory time. It's going to get back to zero. Or increasing your inspiratory flow rate, which is going to make a decreased IDE ratio. So look at this. So in those patients, you can see you spend a smaller time in inspiratory, I. So you spend a longer time in expiratory. Remember, because it takes a shorter amount of time to inspire that same volume. And that's going to prolong your expiration, allowing it to go back to zero. I think that's everything. I hope this helped, because I think, this is kind of some of the more advanced stuff for, ventilation. So if anyone has any questions, happy to answer any of them. All right, thank you.